power over doctors and hospitals in terms of the fees that they can charge, because it's the only payment system. Insurance companies are gone, so we're not going to have this motivation to deny claims. We're not going to have this, certainly. We don't have that now with the regulation, but that could go away. And we're not going to have this. So all those issues disappear. Patients are going to be able to use the healthcare system more because they're not going to have to pay out of pocket for it. Going to use only healthcare providers approved by one's insurer. That disappears. There aren't going to be networks anymore. It's a national system. All doctors are going to have to participate in it. All hospitals are going to have to participate in it, or else they're not going to be able to get patients. The only patients they could get are those who can pay out of pocket, which is a tiny percentage of the population. Might you have boutique hospitals and boutique private doctor practices that cater to the very wealthy? Yeah, well, you have that now, and that would probably continue. But you wouldn't have to worry about a network. So if someone told you, hey, I got this great doctor, be perfect for you, you can go see that doctor because you'll be covered. There is no issue with emergency rooms and so forth. All of that is covered. Medical bankruptcies should drop drastically, but it depends on how Medicare for All is going to be structured. The way it's being talked about is that it'll be a system in which there are no premiums, no co-payments, and no deductibles. If that's true, and it's going to be more expansive than current Medicare, it'll cover vision, it'll cover hearing, it'll cover dental, etc. If that's the system that we have, which is what the Canadians have, then all the things I just said would certainly be true. What's true of Medicare today is that premiums are very low. They're based on income. And they also, you don't have networks. So I have Medicare now. I could see any doctor I want. They all take Medicare anywhere in the country. Overwhelmingly, they do. I shouldn't say they all do. They don't all do, but 90 some odd percent do. If it was the only system, then they all would. So a lot of the problems that we have today in terms of access would disappear, because that's the basic problem that we have with our healthcare system, is accessing it. The system itself is good, but access to it is so limited. Okay. Before we move on, I'm going to give you your your ninth opportunity to earn extra credit. Here's the phrase. It's from Saturday Night Live. ELF motivation. So type that into an email, send it to me, and you'll be eligible for extra credit. The U.S. leads the world in health expenditures. We're going to look at 5 different therapies or products, and we're going to compare what it costs in the United States to what it costs in some other countries. Angiogram is a heart procedure to open up a heart valve. Colonoscopy is a cancer screening. Hip replacement. Lipitor is, I believe, if it's not the #1 selling prescription drug worldwide, it's certainly in the top 10. It's a cholesterol drug. And an MRI scan, you guys know what they are. So, an angiogram costs about $914 in the United States. It costs $35 in Canada. Colonoscopy, about $1,200 in the United States, $35 in Switzerland. These aren't out-of-pocket costs. These are what the procedure costs. Hip replacement, $40,000 in the United States, $7,700 in Spain. A month's supply of Lipitor, $124 in the United States, $6 in New Zealand. An MRI scan, $1,100 in the United States, $300 in the Netherlands. Right, this is from the International Federation of Health Plans in 2012. Why? Why do we pay so much more? If you watch the films carefully, especially Sick Around the World, you know what the answer to the question is. We don't regulate prices in the United States. Each of these other countries that we see in the chart, they regulate prices. They don't leave themselves at the mercy of providers to establish prices. Prices are set by the single-payer insurance system or by the government itself. So consequently, you see these much lower prices. Another reason why prescription prices, like for Lipitor, are so much higher in the United States is because they are lower in other countries, and the manufacturers of prescription drugs, some of whom are American companies, some of whom are foreign companies, they sell their pharmaceuticals all around the world. And they charge more in the United States in order to make up for the lower prices that they are required to charge in other countries. So in essence, we as Americans are subsidizing low prescription costs in other countries because our market is largely unregulated. You saw in Sicko a piece about the prescription drug benefit that was added to Medicare. And one of the features of that is that the federal government cannot negotiate prices with pharmaceutical companies. So let me explain this phenomena. Walmart has pharmacies. Walmart is probably the largest pharmacy chain in the United States. Same thing, you could say the same thing about Rite Aid and all the big pharmacy chains. When they buy prescription drugs from manufacturers, they don't allow the manufacturer to simply charge them whatever they want. They negotiate the price. And because they're buying so much of these pharmaceuticals, they can negotiate a good price. The federal government can't do that. They're banned by law from doing that. So when they buy Lipitor, the manufacturer of Lipitor charges Medicare whatever it wants, and Medicare writes the check. That's why prescription drugs in the United States, at least one of the reasons why they're so expensive. Now, health insurance premium costs. One of the complaints that you hear about Obamacare is that it's still expensive. And it is. But let me clarify something. Two things. First, Obamacare is not insurance. Insurance is provided by private insurance companies. Obamacare is a regulation of that insurance market and an attempt to help people purchase private insurance by granting them subsidies in the form of tax credits. That's what Obamacare ultimately is. People complain that premiums are rising and they're getting expensive under Obamacare. Well, let's go back to 2000. Obamacare doesn't kick in until 2010. Let's go back here. 2000. Family health care premiums went up 11%. 2001, they went up 10%. 2002, they went up 13%. 2003, they went up 13%. 2004, they went up 10%, 9%, 6%, 5%, 5%, 2.5%, and then insurance companies got nervous when the new law kicked in and premiums went up 9% before those policies started to be written. So the point is, to say that a problem with Obamacare is increases in insurance premium costs is a difficult argument to really advance, because for the 10 years prior to the enactment of Obamacare, insurance premiums were rising, in some cases by double digits, for several years in a row. And remember, this downward trend here doesn't tell you that that premiums are declining. It's saying that the rate at which they're rising is going down, but they're still rising by 4%, 5%, 8%, and so forth. And at the same time, workers' earnings were not going up by nearly the same amount, and inflation, the cost of other things, was not going up nearly at that rate. So health insurance premiums were rising faster than the rate of inflation, and they were rising faster than the rate at which workers' earnings were rising. If we look here, workers are paying more of the bill. The workers' share of healthcare premiums have risen at a faster rate than employers' share over the years. So here's 2000. That's the average healthcare plan. Costs a little bit over $4,000. Let's say about $4,500. This was the employer contribution. This is the employee contribution. Move it along, and now we see that the employer, if this will work, the worker contributions have gone up 131%, while the employer contributions have gone up 113%. The cost of a family plan in 2011 was about $15,000, $4,100 paid by the worker, $11,000 paid by the employer. I would think that both groups, employers and workers, would be motivated to move away from this private health insurance system, which is extremely expensive and getting more expensive by the day. Now, take a look at this so you are not misled by some of the things that you're going to be hearing about the rising cost of insurance premiums. We're looking now at an analysis of 2016 premium changes in the Affordable Care Act's health insurance marketplaces. Let me explain what that means. States under the Affordable Care Act were given money to establish what are called health insurance exchanges. We have one in New York. It's called the New York State of Health. It's a website. You go onto that website, and you'll get a listing. You'll give them your address, and they'll give you a listing of every health insurance company who sells policies where you live. And then it will tell you the basic costs associated with each policy, and it breaks them down to 3 levels: gold, silver, and bronze. The gold plans have the highest premiums but the lowest deductibles. The bronze plans have the lowest premiums but the highest deductibles. The silver plans are in between. You could look then at every insurance plan that's available to you based on where you live. You can see how much it will cost, what the deductible will be, what the co-payments are. You can see what doctors and hospitals are in each insurance plan's network. And then you can then shop around and pick the one that you want. It'll also tell you if you are eligible for a subsidy, how much that subsidy would be. If you're eligible for Medicaid, then you would get a Medicaid plan that wouldn't cost you anything. So those are at the Affordable Care Act health insurance exchanges or marketplaces. A lot of states, and I don't want to sound like a broken record, but it's states that are run by Republicans, refused to establish those healthcare exchanges. And the federal government created an exchange for states that don't have their own exchange. And that's the federal marketplace. So if we look at this, I'm going to look right here. We're looking at, in this chart, the monthly silver premiums for a 40-year-old non-smoker making $30,000 a year. And we're looking at the middle plan, the silver, before the tax credit and after the tax credit. And we're looking at the change from 2015 to 2016. And you see the average change, the average insurance increase was 10.1%. But that's when you add up all these numbers and then divide by these states and then divide by 50. And that gives you I don't want the newsletter. That gives you the average. The weighted average does it by population. Because obviously there are a lot more people getting health insurance in New York State than there are in Alaska. So you have to weight it by population. And when you do that, the average increase is 3.6%, which, if you remember, the 10 years prior to the Affordable Care Act, they were going up on an average much higher than 3.6%. But if you factor in the subsidies, insurance actually went down 0.7%, weighted, 0.2% unweighted. I'm going to explain to you how that happens when I show you some other numbers. But beware of the politician who says insurance rates in Alaska, in Anchorage, Alaska, went up 31%. Obamacare is a failure. It went up 17%. In Phoenix, it's a failure, and so forth. You have to look at the average increase after the subsidy. And you see, most of those, there's some exceptions like Phoenix, most of those are 1% or less, right, as you scroll down. Some of them are higher, but most of them aren't. So you have to keep that in mind. In New York, they've gone down 1%. So beware of the person who cherry picks data. That means, yeah, you're using aggregate data, but you're only picking out those pieces of data that support whatever preconceived notion you have or whatever agenda you are trying to advance. You want to see all the data, not just some cherry-picked data. Okay. The Affordable Care Act subsidies for silver plans in 2019. This is the latest numbers available. So first we're going to look at federal poverty limit thresholds so you can see what they are. Because what you pay is going to depend on your income level. What percent of the federal poverty line are you at? So for a single person, that's the poverty line, 12,140. So 200% of that is double this, 24,280. Right? Then family of 4, there's that figure I shared with you when we looked at poverty, at 25,100. Double it, 50,200. All right, 200%. Now, if you earn up to 133% of the federal poverty line, your expected contribution is 2.08% of your income. If you earn 150 to 200% of the federal poverty line, your expected contribution is between 4.15 and 6.54. 4.15 at 150%, 6.54 at 200%, and then proportionally in between. So as an example, let's take someone who's at a single individual, living alone, 200% of the federal poverty line, they earn $24,000 a year. Their premium will be $132 a month, approximately, for a silver plan. It doesn't matter how much the silver plan costs. You pay based on your income. So politicians who thought they were very clever and they took action designed to drive up the cost of premiums by a variety of techniques, wound up just driving up the cost of health care to the federal government. People were paying, most people who get their insurance on the exchanges are getting subsidized insurance. So it doesn't matter if the insurance rate went up 10%. If the person's income didn't go up, their premium didn't go up. It's income dependent, not based on the size of the premium. Okay, let's continue. This was in the New York Times. Few affected by rising Obamacare premiums. Here's where all Americans, adults and children, get their health insurance if they have it. So 46% get their insurance through their employer. By far, it is the largest single source of insurance, is the employer. And by the way, just so you know, the employer-based system, that your health insurance is a benefit you get from your employer, that dates back to World War II. During World War II, there were wage and price controls in the United States. So employers were not allowed to raise their employees' wages or lower them. The wages were controlled. So if an employer wanted to attract better workers or more workers, they couldn't do it by raising wages. So they did it by adding benefits. And one of those benefits was health insurance. And that was the genesis of the employer-based health insurance system, if you can call it a system, that we have in the United States. So it was created in the 1940s, and does it have to be forever? Well, of course not. Medicare covers 18% of Americans. Medicaid, CHIP, is Child Health Insurance Program, something that was championed by Hillary Clinton. Non-Obamacare, that is the original Medicaid, and CHIP covers 16.2%. That's the non-expanded Medicaid. The Obamacare specific health insurance, that is Medicaid and CHIP expanded and subsidized private plans, 7.2% of Americans. Unsubsidized private, 3%. So when you look at those big increases in insurance premiums on the Affordable Care Act's exchanges, that impacts 3% of the population. This percent of the population is not getting their insurance through those exchanges. They're getting their insurance from the employer, and the employer is negotiating premiums with insurance companies. 1.2% get other health insurance, like through the VA, for example, the Veterans Administration. And then 8.4% were uninsured. This was in 2017. We know that percentage has gone up in 2017, it's gone up in 2018, and it's gone up in 2019 as well. We're back up to about 10% uninsured. How successful has Obamacare been? You could take a look at this from 2017. And certain things have been good, other things not so much. Successes: 20 million more people have health insurance when Obama left office. It's made Americans more financially secure. It's reduced inequality. In an era of growing income and wealth inequality, Obamacare was a starkly redistributive law. That is, it took from the wealthy, gave to the poor. Not only did it subsidize health insurance for those with low and middle incomes, it also raised taxes on high earners, which have been wiped out by the 2018 tax law that we looked at last time. This mix of policies made the law controversial, but it also furthered the Obama administration's goal of narrowing the gap between rich and poor Americans, getting the United States moving to the left on that